places. And plus, we are also having our birthday celebrations by the end of it. I hand over the mic to Dr. Yogen Bhatt, sir.
Good evening, everybody. It is a great pleasure to have all of you here to attend a small meeting of a small branch where we are celebrating the 7th birthday of the new branch, which is on the outskirts of Mumbai. As a president, I'll first welcome all the other neighboring area presidents who are going to attend this meet. The list I have is nice and pleasant. We have Dr. Smita Shah from Kalyan, Dr. Vijaya Patil from Mumbai Metro, Dr. Anita Roy, Navi Mumbai, Dr. Maya Bhalerao Madam from Pimpri Chinchwad, Dr. Pradna Bhalerao Madam from Pune, Dr. Meenal Gadgil from Thane Group. I welcome all of you. It is a great pleasure to have all of you here to celebrate a small meet. A topic kept is on post-op nausea vomiting, because simply celebrating a birthday is not going to make meaning. Small talk on some topic has to be there, which makes it more interesting. So I welcome all of you. Thank you very much. Dr. Shilpa can now welcome all the friends.
Yeah, now I hand over to Dr. Neelam Nalge, Madam, our Joint Secretary and GC member. Madam, are you there? Dr. Neelam Nalge, Madam.
Yes, I'm there. Hello.
Yeah, yeah.
Good evening to all friends and all esteemed guests today. We welcome you all on behalf of the 7th birthday of our branch. So I'm specially welcoming all the GC members of the neighboring branches. I would just like to take the names. The GC members of the Mumbai Metro branch, Dr. Indrayani Madam, Dr. Deepa Kane Madam, and Dr. Satish Kulkarni Sir. We welcome you to our branch small webinar on post-op nausea vomiting. Second, I would like to invite Dr. Varsha Vyas from Navi Mumbai. She's a GC member from Navi Mumbai. So welcome Varsha Vyas Madam. She has joined. I hope they have joined. Hello.
Hello, Madam. Yeah, they're joining.
Hello.
Yeah, Madam, you can continue.
Yes, then I welcome Dr. Parna Thakkar from Thane branch and Dr. Preeti Nanda from Kalyan branch. We would also like to invite our special guests from Pune branch, Dr. Archana and Dr. Pallavi from Pune branch and Dr. Sumit Lad from Pimpri Chinchwad branch. These all GC members we have specially invited to celebrate our 7th birthday. Welcome all. Over to you, Shilpa.
Yeah, now we have all the secretaries of the neighboring branches with us. We begin the first talk today by a pathophysiology of post-operative nausea vomiting by Dr. Seema Suryavanshi Madam. Dr. Seema
Hello, Shilpa. Are you, am I audible?
Yes, yes, Madam.
Yes, Madam.
Yes.
Okay. At the outset, I would like to thank President ISA Borivali, Dr. Yogen Bhatt Sir, Dr. Shilpa Tivaskar Madam, Secretary of ISA Borivali branch, for inviting me to this webinar today. I also extend my heartfelt thanks from Team SAPC to the Team ISA Borivali for completion of 7 years of your tenure. I think I should begin with my talk. Can I share my screen?
Yes, Madam.
Okay. Shilpa, is my screen visible?
No, Madam.
Okay. Just a second.
Is
Is it visible now?
Yes, yes, madam. You can start.
Yeah. Okay. Good evening, everybody, all the respected senior persons and my dear colleagues. Today, I'm just going to talk about the pathophysiology of nausea vomiting, post-operative nausea vomiting rather, that is PONV. PONV is a complex and significant troubling problems in anesthesia practice, it being the second most common complaint of patient dissatisfaction. And the incidence of nausea goes up to 38%, and vomiting, it is as high as 80% in the high-risk patients. So how does it affect? PONV, it affects the patient satisfaction, it prolongs the hospital stay, increases the unanticipated hospital admissions, it delayed return to work of the ambulatory patients. Then PONV complications are, some of the major complications of PONV are wound dehiscence, some pulmonary aspiration, there is anorexia, dehydration, and in some patients with anti-cancer chemotherapy and radiotherapy, there is also psychological impact of nausea and vomiting. So actually nausea and vomiting are different clinical entities, and they can occur anytime during a clinical procedure. But as far as they are defined, it is any nausea, retching, vomiting occurring during the first 24 to 48 hours of the surgery in inpatients, that is post-op nausea vomiting. Then it can be classified as early, which is occurring within 0 to 2 hours after surgery, the late PONV occurring from 2 to 24 hours after surgery. And there's a term called PDNV. PDNV is the post-discharge nausea vomiting. It is defined as the presence of symptoms following discharge up to 72 hours. Now, the act of vomiting, it consists of 3 steps: nausea, retching, and emesis. Nausea is simply an unpleasant and difficult to describe psychic experience. It is just a subjective feeling of need to vomit. Physiologically, it is associated with decreased gastric motility, and there is an increased tone in small intestine. Retching is spasmodic respiratory movements within a closed glottis, and there is no expulsion of vomitus. And emesis is the actual expulsion of the gastric and small intestinal contents out of the mouth due to the contractions of gut and thoracoabdominal wall. Now, these are the pathways of vomiting, nausea and vomiting. Just like any other reflex, nausea and vomiting also has a afferent pathway, a central mechanism, and an efferent pathway. So what are the afferent pathways involved? Afferent pathways involved in stimulating vomitings are chemoreceptor trigger zone, vagal mucosal pathway in GI system via mechanoreceptors and chemoreceptors, neuronal pathways from vestibular system, reflex afferent pathway from the cerebral cortex, and the midbrain afferents. The efferent pathways are motor impulses that cause vomiting are transmitted from the vomiting center by 5th, 7th, 9th, 10th, 12th cranial nerves in the upper GIT, vagal and sympathetic nerves to the lower GIT, and spinal nerves to diaphragm and abdominal muscles. Now, the brain structures which are involved in this pathophysiology of PONV are vomiting center, the chemoreceptor trigger zone, the nucleus tractus solitarius, that is NTS, which is triggering vomiting by stimulating the rostral nucleus, nucleus ambiguus, ventral respiratory groups, and dorsal motor nucleus of vagus. Also, there are some receptors involved in this pathway, which are dopaminergic, acetylcholine, histaminic, and serotonin. So in what we see is there are some inputs like fear, dread, anticipation, sometimes inner ear motion, blood-borne emetics, vagal sympathetic, glossopharyngeal afferents, all leading to the respective centers in the brainstem, which will again stimulate the vomiting center in the medulla, and then that will cause vomiting. So let's see what is vomiting center. It lies in the medulla oblongata within the reticular formation and the nucleus of the tractus solitarius. Vomiting center can be activated directly by the irritants, indirectly following the input from GI tract, from the chemoreceptor trigger zone, by the movement or by pain or by hypoxia and hypotension. Vestibular system is being activated primarily by the movement. After the movement, there is stimulation of receptors in the vestibular labyrinth of the inner ear, which sends information to the brain via the cranial nerve, that is vestibular cochlear nerve, and the main receptors involved are muscarinic receptors and histaminic receptors. Then there is again vomiting arising because of psychiatric disorders and stress, which is basically central nervous system mediated. Now the CRTZ. CRTZ is located at the end of caudal end of the fourth ventricle in the area postrema. Stimulation of different receptors such as dopamine receptors, serotonin receptors, opioid receptors, acetylcholine receptors, receptors for substance P, all lead to MSS. And from where does the CRTZ receives input? Vagal afferents, emetogenic toxins, metabolites, and drugs circulating in blood or CSF, because it is also affected by the drugs circulating in blood and CSF due to its lack of blood-brain barrier. So what we have, CRTZ is stimulating NTS. NTS is also receiving vagal, stimulation from vagal afferents, vestibular system, limbic system, and all this, it is being projected to the vomiting center. The factors, apart from these, there are many factors which predispose to MSS or PONV. So these are multifactorial. They can be patient factors, pre-operative factors, intraoperative factors such as surgical and anesthesia, and the post-operative factors. Let's just have a look in short. What are these? Patient factors, the predisposing or what we call as a high-risk factor patient factors are found more in women, motion sickness patients, patient with history of motion sickness or vomiting. Then non-smokers are more prone for PONV. Age less than 50 years. Obesity doesn't have as such any correlation, but delayed gastric emptying, especially in patients with abdominal pathology, diabetes mellitus, hypothyroidism, pregnancy, increased intracranial tension, if there is any history of swallowing blood, full stomach, all these can predispose to PONV. Pre-operative factors as such, they don't have like pre-operative fasting or anxiety. There is no as such clinical correlation to the PONV. Then we have surgical factors, which are very important. Type of surgery such as abdominal surgery, cholecystectomy, gynecological surgeries, laparoscopic, middle ear surgeries, tonsillectomy, adenoidectomy, herniorrhaphy, and strabismus surgery, especially in children. They are known to predispose to PONV. As the longer duration of surgery, the longer duration of anesthesia, and of course, there is an increased incidence of PON. Now, anesthesia factors. General anesthesia, nitrous oxide, use of inhalation agents, volatile inhalation agents are known to be primary cause of PONV, that is early, 0 to 2 hours after surgery. This was more with ether, but less with the use of newer agents like sevoflurane. The intermediate infusion is known to cause more of PONV. Then we have ketamine balanced anesthesia with the use of nitrous oxide, again resulting in increased incidence. Propofol per se doesn't, it reduces the post-op nausea or vomiting, or per se doesn't have too much effect on increasing this episode. Opioids are the it causes the main stimulation of the opioid receptors located in the CTZ, and per se they are more culprit with its use in causing the nausea vomiting. Neuromuscular or the reversal agents, the incidence of post-op nausea vomiting is uncertain. Regional anesthesia, PONV is 9 times less in regional anesthesia than in general anesthesia, particularly the incidence being least with the peripheral nerve blocks, followed by subarachnoid block, followed by epidural, and more with the general anesthetic technique. In post-operative period, the pain or visceral or pelvic pain, any kind of pain can lead to PONV. Sudden motion, changes in motion, transport from post-anesthetic recovery unit to the post-surgical ward. It can also precipitate nausea, vomiting in a patient who have already received steroids or if they are at high-risk patient. So, in short, I'll just sum up with the pathophysiology. So, we have got some trigger, we have got a central mechanism, and then let lead to vomiting center. So, the triggers can be memory, fear, taste, sight, smell, pain, going to the higher cortical centers and stimulating the CTZ. There can be hypotension, hypoxia, increased intracranial pressure, again stimulating CTZ. Drugs, anesthetic agents, opioids, chemotherapy, stimulating the CTZ. which again will act on the vomiting center and resulting in the reflex. Surgery, toxin, gas, abdominal surgeries via the histaminic receptors again stimulate the CTZ. Then we have motion sickness, middle ear surgeries, stimulating the vestibular system, and which again result in vomiting. So this, I think this picture sums up the all pathophysiology of PONV. So thank you for the patient listening.
Thank you, madam. Thank you so much, madam. It was such an elaborate talk. In fact, I think at today's talk, no one needs to speak anything. It was really good.
Thank you, Dr. Shilpa.
Yeah. Madam, with this, we move on to the next speaker, Dr. Manisha Ghosh, madam, who will tell us about the causes of PONV. Manisha, madam.
Good evening, everybody.
Good evening.
First of all, I would like to congratulate ISA Borivali for completing 7 years and having such a successful run. I also wish them all the best for their forthcoming venture, the big CME that is coming, and I'm sure they'll do it very well. Now, the topic given to me was factors affecting and causes of PONV, which actually Dr. Seema Sirovish has already covered everything. So I really don't need to do anything more. I think we can just move on to the next speaker because I think everything she has covered. Shilpa, what do you say? It will just be a revision again.
Madam, we can have your slide just for revision because it is such a day-to-day topic. It is better we can have a revision of him because as it is, it is a short topic. Yes,
because
madam.
It is going to be quite a repetition. Okay.
No, that is fine. Yes, madam.
Okay, chalo.
Yeah, you can please continue, madam.
मैडम वैसे भी हमारे दिमाग में जल्दी घुसता नहीं था.
ठीक है, फिर चलो चलेगा.
2-3 दिन बोलेंगे तो जल्दी घुसेगा.
Okay, but anyway, I am taking this opportunity to invite all of you for the National ISA sponsored CME that we will be having on the 16th of January and request your support for the same.
Yes, sure, madam.
It is our first major venture, so everybody, I am extending a warm welcome to everybody. So the risk factors and causes of post-operative nausea and vomiting. Let's just go through them one by one. The causes are multifactorial and could be from the patient and cover the pre-operative, intraoperative, and post-operative areas. Let us just have a look at them one by one. Gender. Gender is the single most patient-specific factor, and it is more commonly seen in the females. So it is said that it is more during menstruation and the pre-ovulatory phase, probably due to sensitization of the chemoreceptor trigger zone and the vomiting center by the follicular stimulating hormone and estrogens. Previous history of post-operative nausea and vomiting or motion sickness is another major cause of post-operative nausea and vomiting. And third one, surprisingly, is non-smoking. So non-smoking or smoking has that one advantage that non-smoking status, the patients are more prone to have post-operative nausea and vomiting. That is also because of the gradual desensitization of the chemoreceptor trigger zone in smokers. The other patient-specific factors are the age. Age less than 50 years is a significant risk factor. Delayed gastric emptying time in pregnancy, hypothyroidism, abdominal pathologies, diabetes mellitus, intracranial tension increase, and full stomach have again an increased risk of PONV. Obesity, one would assume, would cause more PONV, but recent data says that it is not correlated with an increased risk. Let us have a look at the preoperative factors. We would again feel that perioperative fasting and anxiety would give rise to post-operative nausea and vomiting, but both these causes are uncertain and clinically not relevant predictors. Now, the most important intraoperative factors of PONV are the surgical factors and the anesthesia factors. So the type of surgery is important. Major abdominal and gynecological surgeries, which involve excessive tissue handling, are associated with excessive PONV. Cholecystectomy especially causes a lot of post-operative nausea and vomiting. Laparoscopic surgeries, middle ear surgeries, ophthalmic surgery, especially the strabismus, neurosurgery, thyroid, breast and maxillofacial surgeries are having a high incidence of post-operative nausea and vomiting. The other surgical factor is the duration of surgery. Greater the duration, increase the chances of PONV. Each 30-minute increase in duration increases the risk of PONV by 60%. Let us now come to the anesthesia factors, and there are a lot of anesthesia factors which influence PONV. So general anesthesia has increased the risk of PONV. First and foremost, we have the opioids. Opioids are one of the causes of PONV, and they cause emesis through stimulation of the opioid receptors in the chemoreceptor trigger zone. Hence, the inclination towards opioid-free anesthesia is now gaining momentum in many centers. Nitrous oxide. Nitrous oxide avoidance has been seen to have a significant decrease in post-operative emesis, especially in laparoscopic surgeries. The mechanism behind the increased POV is related to the stimulation of the sympathetic nervous system with catecholamines. Middle ear pressure changes can cause the traction of the membrane of the round window and consequently stimulate the vestibular system, giving rise to PONV. Thirdly, abdominal distension due to exchange of nitrous oxide and nitrogen in gas introduced into the GIT during the mask ventilation has been predicted to have increased PONV. Let us next come to the inhalation agents. Ether and cyclopropane are associated with very high chances of post-operative nausea and vomiting. And the others like sevoflurane and desflurane, which we are using now more commonly, do not have much PONV. The effect of volatile anesthetics is dose dependent, and it is most commonly seen in the first 0 to 2 hours post-surgery. As the time post-surgery increases, the effect of nausea and vomiting due to the inhalational agents just decreases. Induction agents. Induction agents, among induction agents, ketamine, which is used for induction, has the highest incidence of post-operative nausea and vomiting as compared to barbiturates. This is due to the high endogenous catecholamine release due to ketamine. Then the vivid dreams, hallucinations caused by dissociative anesthesia due to ketamine can also cause delayed discharge. The other is etomidate. Etomidate infusions are associated with more nausea and vomiting. So propofol remains the favorite because it has an antiemetic effect of its own, and the nausea and vomiting caused by it is the least. So if we go to see a nitrous oxide opioid relaxant technique has more post-operative nausea vomiting than a pure TIVA technique. So the strongest predictors of the anesthesia factors would be volatile anesthetics, duration of anesthesia, post-operative opioids, and nitrous oxide. Regional anesthesia is of course a favorite now with everybody, and the risk of PONV is 9 times less than general anesthesia. The risk of post-operative nausea and vomiting is even less with peripheral nerve blocks as compared to central neuraxial blockade. Central neuraxial blockade is associated with sympathetic nervous system blockade, which leads to hypotension and thereby nausea and vomiting. Lipid solubility of opioids is also important. The more lipid-soluble opioids such as fentanyl and sufentanil have a lower incidence of nausea and vomiting as compared to the less lipid-soluble ones like morphine, which is due to the decreased rostral spread from the lumbar or epidural injections of the opioids. Coming to the post-operative factors, pain, ambulation, and opioids are 3 factors which can cause post-operative nausea and vomiting. Visceral and pelvic pain causes POE. Sudden motion, sudden change in position and transportation can precipitate nausea and vomiting. Opioids in the post-operative period can again increase post-operative nausea and vomiting, which is again dose and time dependent. This can be offset by the use of non-steroidal anti-inflammatory drugs and other analgesics. Now let us just have a look at the risk scoring system. The most commonly used risk scoring system is the Apfel score and the Koivu-Ronta score. Now the risk factors are 4 and each risk factor has 1 point. So female sex is the highest risk factor and has 1 point. Non-smoker, 1 point. History of post-operative nausea or vomiting in the past or a history of motion sickness gives you 1 point. And post-operative opioids gives you 1 more point. So a young female who's a non-smoker and who has a previous history of motion sickness, if she receives post-operative opioids, there are highest chances that she may have lots of post-operative nausea and vomiting. So from this table, we can make out that if the point is 0, still there is a probability of 10%. And as the point increases to 4 points, the probability of nausea and vomiting in the post-operative period goes to 80%, which is pretty high. A quick look at post-operative vomiting in children. Now, in children, we do not include nausea because they may not be able to enunciate clearly what they mean by nausea. However, it has been seen that POV is rare in children less than 2 years. It increases with age more than 3 years and decreases as they reach puberty. The high-risk POV surgeries in children are strabismus, tonsil and adenoid resections, hernia, orchidopexis, and penile surgeries. To summarize, as the risk factors increase, the probability of having post-operative nausea and vomiting also increase. How would you reduce the risk? Prefer a regional over a general anesthesia. Use propofol for induction and maintenance. Go low on the nitrous oxide and volatile anesthetics. If possible, avoid opioids and maintain adequate hydration of the patient. Now, in spite of all this, PONV may still occur. And how to tackle it perioperative period will be told to us by the next speaker, I think Kala Ishwaran. Thank you all for a patient hearing.
Thank you, Manisha madam. Yes, that was very nice revision and very specific. Yes, some points which I had missed, I could revise it nicely. Yeah, thank you.
Thank you,
really, all of you are really great bosses, and you put the topic so nicely. Yeah, over to the next boss, Dr.
I think Manisha, hello. Manisha has almost covered whatever I'm supposed to do. We will have a comparable slide study, I feel now.
Asudhya, that thing comparable mat karo. You do your whole talk वापस. कितना भी repeat करेंगे ना nausea vomiting कम नहीं होता है. So let it go on. Doesn't matter.
Treatment नहीं है ना मेरा preventive measures.
Doesn't matter. So even if I give 4 drugs and someone tells me a 5th one helps, I still give that to each patient. मैं और शिल्पा मैडम साथ में बैठे मेरे ऑफिस में हम लोग की ऑफिस में.
That's nice. Okay. Thank you, YB sir and Shilpa madam and ISA Borivali to have me, and very happy birthday to ISA Borivali. And you all have been scaling so much heights. God bless you with many more awards. And so I'll just go. Why the importance of PONV? Why are we stressing so much or repeating the same thing? It's like PONV is the second major cause of complaint next to pain in a post-operative patient. It gives immense patient distress, and there is severe morbidity with severe PONV. There is aspiration chances, electrolyte imbalances, the tension on the suture lines, dehydration, and delay to normal or recovery. All these can lead to prolonged stay, hampering the ERAS protocol. Enhanced recovery programs depend greatly on the ability to support patients with early nutrition, multimodal analgesia, and ambulation, none of which can be achieved unless your GI tract is functioning normally. And all these can actually cause us both dollars and the patient satisfaction. Now, the term prehabilitation. This is a term which allows you to optimize the patient for considering all the factors, and PONV happens to be one of them. And this begins in the pre-operative period. The step 1 is risk stratification or target the at-risk patient. In defining a PONV prophylaxis strategy is to determine which patients are most likely to develop PONV, and through numerous considerations like the patient factors, pre-op factors, anesthetic factors, surgical factors, and the post-operative factors, we come to the simplified APFL score, which Manisha has explained. I will not go, just that each risk factor increases the risk of PONV by 20%. And many studies have been done to know the usefulness of this Apfel scoring system, and if it presented the favorable discriminating and calibration properties for predicting the risk of PONV, and hence many hospitals have implemented this in their daily practice. And going further, this is available online. You can just Google Apfel and you get this, and you can, in front of the patient in the PAC itself, you can put the risk factors and show the patient their score. That way you can explain. And I just Googled, so I got Kristen Apfel. You can befriend him on the Facebook. And this is the classification for children. This again was explained by Manisha. I will not go through that. Only thing, with the Apfel, what drugs you can give. The drugs and antiemetics will be covered in the next lecture, but this is just to show that even with the risk factor of 0, the prevalence of PONV is 9%, and the prophylaxis number of antiemetics, you have to give at least 1, even when the risk is 0. And the preferred one is ondansetron. When the risk score is 1, 20% risk in the PONV, and you have to give 1 or 2 antiemetics. When the risk score is 2, it's almost 40%, 3 is 60%, and 4 is almost 80%. Combination should be with the drugs that have a different mechanism of action, and you should not repeat the same drugs which has been given in the operation theater or in the PSU for treatment. Now, prophylaxis for PONV can be pharmacological and non-pharmacological. Pharmacological antiemetic drugs, these are the various drugs which will be covered in the next lecture. But you have to remember that there is a first class and the second class drug classification, just to show that the prophylaxis, where it starts at the induction, and some even the night before or day of the surgery, okay? And some are before induction. So it's not, you have to preemptively, here again the term prehabilitation, I'll stress upon that. You have to do that for prevention of PONV. Now, what is a general multimodal prophylaxis? There was a time when only when the patients were vomiting, we used to give them the antiemetics. But then came a time when just one drug was used. But now it is, because we are entering the ERAS protocol, the standard of care is multiple antiemetics, because PONV scores only provide the risk stratification. Low risk patients may also develop PONV. PONV scores do not take into account the emetogenic risk of the surgeries, and antiemetics effectiveness varies between patient to patient. Now, what is the novel risk reduction measures? First, again, I'll go to the prehabilitation is LA anxiety. Anxious patients are more prone to post-op nausea and vomiting. The fasting has to be minimal in the REST protocol. Optimizing fluids and hydration should be optimal. Optimizing the oxygenation and optimizing pain relief, more so in the fracture patient, you can give preemptive pain relief before the surgery itself. Supplemental fluids. The perioperative fluid status is a most important risk factor in PONV. The role of preoperative carbohydrate loading alters the risk of PONV. Now, what is carbohydrate loading? You can give 400 ml. You get these drugs like pre-op drug or Ensure drink, which is of carbohydrate. 400 ml of this drink 2 hours before surgery, versus they have done a study versus full fasting against 4, and they have studied the gastric pH, the residual volume, the PONV, and the antiemetic consumption post-operatively. And they have found that the patients with carbohydrate loading fared far better than the fasting patients. And it improves the patient satisfaction also. Intraoperatively, you have to give 10 to 30 ml per kg of crystalloids, significantly reduces the risk of both early and late PONV and the need for rescue antiemetics. In some studies, they have said that you have to give around 1 liter pre-operatively crystalloids to get and it significantly reduces the PONV risk. Colloids here fare better than the crystalloids if the surgery is of longer duration, that is more than 3 hours. Oxygen. By providing 80% oxygen post-operatively and intraoperatively, it reduces risk of PONV. Propofol, as Manisha already described, Tiva with propofol fares far better than inhalationals, and the subhypnotic doses of 20 to 40 milligrams can even work as rescue treatment for PONV. General anesthesia with inhalationals increase the risk of PONV by almost 10-folds than the when you do without GA and without inhalation, that is Tiva. Now, ketamine, low-dose ketamine gives good quality recovery. It has analgesic property also, and it has known cause reduce in the PONV. But how? By reducing the consumption of opioids. So it's not a direct result. And high-dose ketamine, as Manisha had already said, it exacerbated the PONV, especially in high-risk patients. Nitrous oxide sparing anesthesia. Avoidance of nitrous oxide, especially in surgeries lasting more than 2 hours, was beneficial to reduce the risk of PONV. Reversal of neuromuscular blockade with Sugammadex. Sugammadex, unfortunately, is not available here. Neostigmine and acetylcholine esterase inhibitor increases the GI motility and secretions. Reversed with NMB reversed with neostigmine showed high incidence of PONV. So you should avoid using higher doses of neostigmine. As far as possible, use shorter acting muscle relaxant, or if possible, avoid using muscle relaxant. Lidocaine infusion. IV lidocaine gives good, effective analgesia, and hence it causes opioid sparing. And this can, and by the secondary outcome, it can help in reducing the PONV. Dexmedetomidine, as Manisha had already said, highly selective alpha-2 adrenergic agonist with sedative and analgesic property, reduces opioid requirements. IV or regional anesthesia adjunct can help in reduce the chances of PONV. It can be either given as a single bolus or in continuous infusion. Opioid-free anesthesia or analgesia, loco-regional, one of my favorite techniques. Even simple LA infiltration along the surgical incision can go a way to reduce opioid requirements. Regional anesthesia use as sole anesthetic agent or as an adjunct can help reduce the PONV. And peripheral nerve blocks fare better than the central neuraxial blockade. There is no literature to compare opioid-free to opioid-sparing approach here, but both are much less opioids are required with locoregionals. Other factors includes allaying perioperative anxiety. Anxious patients are prone to more PONV. Hypotension, correct the hypertension and hydrate the patient well. Avoid hypoxia, avoid hypoglycemia. Blood in the pharynx can lead to nausea and vomiting. Intestinal obstruction or omental pool, where the surgeries cause these, there can be PONV. So try to treat them preemptively if possible. And pain. Pain is one of the major factors leading to PONV. Try to give very good pain control. Use multimodal analgesia techniques. Most chemo prophylaxis, most utilized multimodal prophylaxis is combination of dexamethasone and ondansetron. Other therapeutic options, I will just go directly to Mirazolam, which is routinely used, I'll say, by many obstetric anesthetists when patients start complaining of nausea, vomiting post mithurgin and your prostadine during the surgery. So Mirazolam is intraoperatively, it acts good, but post-operatively it leads to sedation, hence avoided. Non-pharmacological acupressure and acupuncture, I'm not aware and I've not seen them being used. So the novel therapies for avoiding and prevent PONV is multimodal, is more effective than monotherapy. It lowers the dose of individual antiemetics and thereby their adverse reactions. PONV and ERAS pathways, all patients should receive PONV prophylaxis. Multimodal is preferred, at least 2 agents, and prompt rescue treatment to be given whenever needed. To summarize, assess the baseline risk with the various scores, inform the patient, show them the scores, and give them the possibility and the range where they are in, decrease the baseline risk preemptively, preoperatively and intraoperatively as much as possible, and prevent them and treat them as soon as needed. Thank you.
Dr. Kala, it was a really, you had a different touch to the topic, I would say. That rehabilitation and the drugs and actually that pre-op also matters a lot. Yes, I've seen that. And the antacids and the drugs that you said, it was really a good revision. Thank you so much. Yes.
Thank you.
Yeah, we go on to our next speaker, Dr. Shweta Madam. Madam, you're there? Dr. Shweta Salgaonkar Madam. I think Madam is there. Dr. Shweta Salgaonkar Madam, can we have you on board? Dr. Shweta Salgaonkar Madam, you there?
I think you can call her, Shilpa.
Okay, because Madam was there actually. Okay, Bhatt sir is calling her. Should I? Okay. Okay. Should I finish my talk, sir? No? Okay. Fine. So Shweta Madam is again logging. Till then, I wanted to know about the newer drugs. Does anyone use any newer drugs for post-operative nausea vomiting? Anyone from the audience, anyone from BSM members or the faculties?
Between they were pushing droperidol a lot.
Droperidol and yeah.
Because the droperidol had gone out of use and probably they were looking for newer markets. So they were just trying to push it as an anti-emetic. It did not work really that well. Probably the market did not pick up it. I don't know how effective it was, but it did not work.
Yeah, and one more concept which is there is for all ASA1 patients, even without the risk of post-operative nausea vomiting, how many of you still give ondansetron, still give metoclopramide? Can we have hand raised? Can we have some answers?
should ask how many are not giving, because everyone gives the whole combination.
Yeah,
Yes,
Ondansetron and dexamethasone, I think I am giving to almost all my patients.
yes, yes.
Yeah.
Agree.
I guess all of us are giving because we don't want that nausea vomiting. It irritates us. Besides the patient, it irritates us also. We don't want that to happen.
It is in all pre-op orders of mine, not Dexa,
But I just want.
What is the ideal time to give ondansetron?
Shilpa madam, I just want to ask whether the dexamethasone is
ondansetron.
Yeah.
Ondansetron.
Yes,
It
Maya
is to be
madam.
given before the reversal. Ondansetron. That's what they suggest.
Actually, dexamethasone is not needed, I feel, because I do all the cases of ENT and they do middle ear work and maybe stapedectomy and all these things, but I never give dexamethasone. Only ondansetron suffices. That's what I feel. And maybe for other cases, dexamethasone is not needed. What is your opinion? Other may opine on it.
Maya madam, what are you using for sedation in your ENT cases? Are you using Fortwin, Finargan?
No, never. I stopped using Fortwin long back, maybe 10 years ago. I'm using fentanyl and Mirazolam combination for most of the cases.
Okay. Because with Finargan, I think that it also has that.
No, Fortwin, no Finargan.
No. Yeah, that is why I asked that. What are you
Fortwin,
using?
Finargan, long back. No. Fentanyl and Mirazolam. Aciloc I give and ondansetron, and that's it. I think even for tonsillectomy, coagulation, adenylation, dexamethasone is rarely needed. And believe me, none of our patients they vomit, only except few stapedectomy where we have to give them some other drugs. But dexamethasone is not needed. That's what I feel.
In fact, last month we had a webinar with people who were talking on thyroid. And when we said we give dexamethasone to all our patients, he said, why you give dexamethasone? Why can't you give hydrocortisone to all of them?
Yes.
No? So that way, but in reality, everyone now insists on giving at least 4 milligram of dexamethasone to all patients for prevention of nausea.
Sir, I think Shweta madam has joined.
She has.
You can see her.
Yeah. Then we can have Tendulkar sir and Dipali Kotian madam. We can have the discussion continued later on. Yeah, welcome Shweta madam.
Hello everyone. Good evening.
Good evening, madam. Nice to see you.
Yeah, same here.
Yeah, and congratulations on being secretary of ISA Mumbai Metro.
Congratulations to you, the whole ISA Borivali team and the branch where you all members are so active.
And
at a very young age, you have achieved a lot.
It's just the healthy
Yes. Should be. That's what we want.
It's the friendship and healthy competition.
Yes, of course.
I am also young.
Hello, sir. How are you?
I am also
young. Yes, 100%. You are the most youngest most.
Madam, the reason is
Welcome Ashok Deshpande sir.
Thank you. The reason is both branches are inaugurated by me.
Yes.
Borivali and Pimpins for both.
Yes,
so you are moving very fast. Yogen is sitting there.
Yes, sir is there.
Good to see you. Fine.
Thank you.
Yeah, Shweta madam, you can start sharing your screen.
Okay, I'll do that. Yeah. So, good evening to all, which I did an informal one. The formal one comes now. Well, I'm going to talk about the post-operative nausea vomiting review of literature. And I'll start right because it's a very short talk. So no roadmap or conclusion. Let's start with the literature review itself. Well, it is a 2016 paper in Anesthesia Essays, which tells us a detailed review and systematic analysis of this over a 25 years of duration. So the search engines that used was Medline and PubMed database and that included all the papers from 1991 to 2014. And what it mentioned was that PONV is a patient important outcome. It may sound not much important from anesthesia point of view, but definitely from patient viewpoint, it is very important. And yet it is in major incidence because the pathogenesis is pretty much complex and there is relative lack of concern regarding this issue. I mean, we generally don't bother much about it. Hota hai types of attitude. So, and it is still a significant problem because it has its adverse consequences, which can be delayed recovery, unexpected hospital admission, delayed return to work of ambulatory patient, pulmonary aspiration, wound dehiscence or dehydration. So all of these are significant problems from patient healthcare point of view. It also mentioned that the PONV prophylaxis should be required for patients with a medium and high risk based on the FL scoring system, which we'll be just talking in a while. And newer drugs, which are neurokinin 1 receptor antagonists called as aprepitant, they are used along with serotonin 5-HT3 receptor antagonists, steroids, anticholinergics, antihistaminics, butyrophenones or antidopaminergics for PONV prophylaxis. And combination of drugs are always better with different mechanisms. Multimodal approach, where they include not only pharmacotherapy, but also non-pharmacotherapy prophylaxis, along with the interventions where you try to reduce the baseline risk in patients who are at high risk of PONV. So the goal of PONV prophylaxis is to reduce the incidence of PONV and thus reduce the patient-related distress and the healthcare costs. Well, there is no prophylaxis for patients who are at low risk of PONV, except if they are at risk of medical consequences of vomiting, like patients with wired jaw or with intracranial pressure. There, even if there is a low risk of PONV, we must offer prophylaxis. And when rescue therapy is required, then we must choose an antiemetic from a different therapeutic class, the drugs other than what was used for prophylaxis. If it happens within 6 hours, if it happens after 6 hours of prophylaxis, then we can repeat the same drug maybe. And if no prophylaxis was given, then 5-HT3 antagonist is the commonest which is used. So coming to the individual drugs, what the literature has to say, there were 2 meta-analyses that were done where they had avoided using nitrous oxide and that reduced the incidence of PONV risk. And that is because there is stimulation of the sympathetic nervous system with catecholamine release, or there could be middle ear pressure change resulting from the traction of the round window membrane, and that subsequently may be leading to vestibular system stimulation, or because of the increased abdominal distension, because during mask ventilation, nitrogen might go into the stomach, and then when it gets replaced by nitrous, it can cause abdominal distension, and all these 3 can put the patient at risk of PONV. So avoiding nitrous definitely helps in reducing the incidence of PONV. Coming to inhalational agents and TIVA, well, the older inhalational agents, they cause endogenous release of endogenous catecholamines. So compared to them, of course, the newer ones, which are CON and desflurane, halothane, they are much better compared to ether and cyclopropane, and they have less incidence of PONV. And it is mainly dose dependent and prominent as early PONV, that is within first 2 hours post-surgery. And there is no impact generally on delayed PONV. Etomidate or induction doses of ketamine can also increase PONV incidence. Compared to TIVA, balanced anesthesia technique where we have used opioids and nitrous, that can increase the PONV incidence. So compared to balanced GA, TIVA could be better for reducing the incidence of PONV. Propofol has antiemetic properties and even in subhypnotic doses. So definitely it reduces the incidence of PONV. Alpha-2 agonist, they are like Dexmed or oral clonidine that has been used. They have direct antiemetic effect and opioid sparing effect both. So they are definitely helpful. Gabapentin has been shown to reduce PONV incidence when given in a dose of 600 milligram orally 2 hours before the surgery. or if higher dose is used just 1 hour before the surgery, it works as good as dexamethasone 8 milligram. And combination, if you are giving, it's going to work better than the either drug given alone. Ambulation in patients who are receiving opioids. So there's going to be more increase in PONV. Post-operative opioids, they increase the risk for PONV in a dose-dependent manner. Mirazolam, that's a low-dose Mirazolam, they say given before the end of the surgery, works as good as given 4 milligram of ondansetron for PONV prophylaxis intravenously. Intravenous fluids is a very important point. Adequate hydration reduces the baseline risk of PONV. So if patient who is given restricted IV fluids or not liberal fluids, probably they have a high chance of having PONV. The risk of PONV is 9 times less if we have used regional anesthesia compared to GA. Because obviously with regional, there is going to be sympathetic nervous system blockade, and that's good for reducing the incidence of PONV. What other finding is that supplemental oxygen is no longer recommended for PONV prevention. It doesn't help. Non-pharmacotherapy like pericardium acupuncture point, PC6 stimulation, acupuncture, neuromuscular stimulation of median nerve, all of this decrease the incidence of PONV in the early post-operative period. So this is the role of non-pharmacotherapy in PONV prophylaxis. Coming to the classes of drugs, where 5-HT3 receptor antagonist, ondansetron 4 milligram given at the end of the surgery. So now all these drugs, they have the level of evidence not only with the dose of the drug and the route, but also the timing of when it is given. So ondansetron is recommended at 4 milligram at the end of the surgery. US FDA have given a black box warning kind that never to exceed a dose of 16 milligram. A single dose should never be more than 16 milligram because it can cause QT prolongation. And 8 milligram of oral disintegrating tablet is equivalent to 4 milligram of IV dose. So you can use any one of these. Dolasetron is banned because of the, again, QT prolongation and torsades pointis phenomena. Granisetron has been recommended 3 milligram intravenous. Along with a combination of Dexa 8 milligram, it can be effective, more effective than the drugs given alone. Remosetron, again, the dose is 0.3 milligram IV, which is most effective to prevent nausea, vomiting in patients who are receiving fentanyl-based PCA. Palanoceptrone is a second generation 5-HT3 receptor antagonist. It has got a very long half-life, 40 hours. So you need to give only once in 24 hours. It provokes a conformational change in the HT3 receptor through the allosteric binding. So the most effective dose, single dose, 0.07 milligram intravenous is been recommended for this drug. Anticholinergic or antimuscarinic drugs like scopolamine has got a very short half-life. So it is to be applied 2 to 4 hours before the start of the anesthesia. And that's why it can, because it has got a short half-life, it can be used for as a transdermal. Steroids, dexamethasone, the mechanism being they block the prostaglandin synthesis, which in turn sensitize the nerves, other neurotransmitters involved in the emesis control. So a single dose of 4 to 8 milligram of Dexa is good enough for PONV prophylaxis, but it is relatively contraindicated in labile diabetic patients. As we understand, it can cause loss of sugar control. Methylprednisolone, 40 milligram IV is effective for the prevention of late PONV, long-acting drug. Now, antidopaminergics or butyrophenones, they are amisulpride that is given, it can be available orally and IV also. So 5 to 10 milligram of IV. It has got a level 2 evidence, A2, not associated with sedation or extrapyramidal side effects or no QTC prolongation. So that's the advantage. Now, droperidol is a selective D2 receptor antagonist, and it has got a black box restriction because it can cause significant cardiovascular events. And recent meta-analysis have suggested that you can use a low dose droperidol, which is less than 1 milligram or maximum 15 microgram per kg IV. And that offers better benefit risk ratio. Haloperidol, again, it is not FDA approved. So again, in the view of QT prolongation, metoclopramide dose required is 25 to 50 milligram. It may be effective. So here it has got an level 1 evidence, but it may be effective for the prevention of PONV. Antihistaminics, diphenhydramine, again 25 to 50 milligram. It has got an evidence of A2, A3, promethazine, 25 milligram alone or 12.5 milligram along with ondansetron. It has got a evidence level A2. Now, FDA in 2019 issued a black box warning for IV preparation because it can cause extravasation with the serious damage. If it goes intra-articular for whatever reason, it can cause gangrene. And so what is preferred is that it should be, instead of IV, you should be giving it deep intramuscular injection. Now, there's another paper. I'm sure Dr. Shilpa would be taking this guidelines for the management of PONV. I'm just putting up the important literature findings that we have got it. So these guidelines were given by the American Society for ERAS and Society for Ambulatory Anesthesia in 2020. And these guidelines provide recommendation on identifying the high-risk patient, managing the baseline PONV risk, choices for prophylaxis, rescue treatment of PONV, plus recommendations for institutional local protocol, evidence for newer drugs, and for enhanced recovery pathways. And this set of guidelines have been endorsed by 23 professional societies and organizations from different disciplines. Now, as we talked about this ALFEL score, we will just say that there are four, these are the four predictor score, where 4 predictors are there: female sex, history of PONV or motion sickness, non-smoking status, and use of post-operative opioids. So each of these, we have to give a score of 1, and that's a total score of 4. So this is being, a low category if there is a score is 0 to 1. If it is 2, it is medium. 2 or 3, it is medium category. If the score is 4, all 4 factors are present, then it becomes a high category where patient is likely to have definitely high risk of PONV. That is a patient factor. So the predictors from pre-op, the surgical factors which could be there are this laparoscopic, bariatric, gynecological surgery, and cholecystectomy. All of them have a B1 evidence in the literature where the patients can be prone to PONV. Another important finding that they got is that anxiety, menstrual cycle, neostigmine, preoperative fasting, nasogastric tube, obesity, supplemental oxygen have limited clinical value or uncertain significance or no association. So all of these factors do not affect post-operative PONV. That is definitely clear. This is the modification of further extension of AFL score is the length of the surgery, where it is more than 60 minutes. It is going to increase the risk of PONV. And this is post-discharge nausea, vomiting, where they've included the use of opioids or history of nausea in PACU. So these 2 factors again add on to post-discharge. Patient may require readmission or management because of the nausea, vomiting. Now, how do we identify? We have gone through most of it. Just want to say the nitrous, volatile anesthetics, and opioids are pretty much the culprit, and they have got level A1 evidence saying responsible for post-operative nausea, vomiting. And of course, they are all responsible for early dose-dependent manner and early PONV. While the incidence of PONV is lower with TIVA, opioid-free regional or multimodal management, and use of alpha-2 agonist and blockers. And all of these have a level 1 evidence. So it's good to use regional, avoid opioids, use dexmed, clonidine, and use multimodal pain management. What are the strategies that we have to reduce the baseline risk? You've already talked about the strategy. What is the level of evidence? Well, you avoid GA, that's going to be better for PONV, A1 evidence. Propofol, again, A1 evidence. Avoiding nitrous, A1 evidence. Avoiding volatile anesthetics, A2 evidence. Minimization of intraoperative opioids, A2 evidence. Adequate hydration, A1. This is important. So adequately hydrating the patients is very important. Using sugammadex instead of neostigmine, A1 level of evidence. So what are the further findings that they got it? Prophylactic IV acetaminophen. It as a part of the multimodal analgesic regimen decreases the nausea and vomiting if given before the onset of pain. That has got A1 evidence. So this is a very easy thing to apply. Use IV acetaminophen prior to the painful stimulus is given. Perioperative NSAIDs and COX-2 also, even intraoperative ketamine low dose can all have opioid sparing effect. And so subsequently, it will have a reduced effect on, decrease incidence of PONV. Similarly, all this we've already talked about. What we found, one more thing is the Lignochain infusion, especially for laparoscopic abdominal procedures, where you give a 2 milligram per kg bolus followed by infusion that helps to reduce the incidence of PONV. In few of the RCTs, they have found it. So it is the multimodal prophylaxis in patients with one or more risk factors. So you use at least 2 interventions for patients who are at high risk of PONV. And as I said earlier, it is just not the dose and their what route of administration. It is the evidence is also for their timing, and the level of evidence is also for the timing. So for amisulpride, it is 5 milligram dose, A2 evidence, and at induction, A1. Similarly, epigenetic. So this is also 40 milligram per oral, A1 evidence is there. So we have to see which one works the best here. We have a lot of evidence, enough of RCTs and observational studies to tell us what works the best for our patient. And we need to just pick up have the right choice. And there are guidelines available helping us to, make it easy for us. And that will be presented by Dr. Shilpa. So this is the triple agent combinations generally now. So far it was double agent. Now they are talking about even triple agent. So Aprepitant, which is a Neurokinin receptor antagonist, N1. So that 80 milligram, and dexamethasone 4 to 8 milligram, and ondansetron 4 milligram. So this combination was found to be much superior. This combination is better than this alone, ondansetron alone. Good evidence, A1 and A2 evidence which is there. One more thing that was found through this analysis, the systematic analysis, that music, aromatherapy, carbohydrate loading, all of these have no role in reducing the incidence of PONV. So we have to understand. Coming to our last, what about the epigenetics? The cytochrome P40 2D6 is involved in the metabolism of the several 5-HT3 receptor antagonists. So ultra rapid metabolizers phenotype, they may be associated with the reduced antiemetic effect of all these drugs. So we have to understand they are more prone to PONV. Dopamine receptor 2 gene polymorphism also has been linked to increased risk of PONV. There has been association between the patient ethnicity and the risk of PONV. And it is also high in patients with the homozygote patients with A118 variant of OPRM1. So there are some genetic polymorphism and genetic effects also being there. We have to consider that. So adult management, this is how it have to go. We have to identify the risk factors. How do we do the risk mitigation, reduce the risk, the baseline risk? How do we do the risk stratification, putting them into low, medium, and high category? And prophylaxis is offered. And if this doesn't work, we have all this medications that we talked about, and we have the literature evidence saying what should be used. And we have the rescue treatment where you use a antiemetic from class different than the prophylactic drug. So we have, this is how we have to manage our adult. In the pediatric patients, yes, we have a little bit of risk factors are a little different, where the age is more than 3 years. If there is history of PONV or motion sickness or history, family history of PONV, then or post-pubertal female. So all these are children who are going to be prone to increased risk of PONV. And the type of surgery, well, the strabismus surgery, adenotonsillectomy, ear surgery, surgery more than 30 minutes, and use of volatile anesthetics and anticholinergics, yes, going to put them through increased risk of PONV. Post-operatively, those who are on long-acting opioids, again. So here they have another score, POVOC, which I'm just going to talk about in the next slide. Again, the management remains the same. We do the risk stratification, low risk, then there are no prophylaxis required, or maybe 5-HT3 antagonist or a DEXA single. If there are 1 or 2 risk factors, which is medium risk, we have to give both the combination, 2 drug at least. If more than 3 factors, high risk, then we will have to do this 2 drug prophylaxis plus consider TIVA and avoid nitrous and opioids, etc. And rescue, again, same thing. We have to use class as other than the prophylactic. So this is a POVOC score where the how we do that EPLEF score in adults. Similarly, in pediatric patients, we do the POVOC score where surgery more than 30 minutes is given 1 score, age more than 3 years, strabismus surgery, history of PONV or family history of PONV given 1 score. So again, it is 0 to 4 and it will be like low, medium and high category. So this is how we'll have to treat. Baseline risk reduction, what is the evidence? Yeah, TIVA if we give, it has got a level 1 evidence. Liberal fluid therapy has got A3 level of evidence. Opioid sparing, again, A1. All this is going to reduce the PONV. Lignocaine bolus reduces intranasal dexmed. This is very important in pediatric patients. The separation anxiety can be reduced by using this intranasal dexmed. So it is an important trial which shows that intranasal dexmed is better than intranasal Mirazolam or oral Mirazolam, has got level 1 evidence. Perioperative IV acetaminophen, again, it has been found to significantly reduce risk of PONV. So acetaminophen is very helpful. Paracetamol IV as a preemptive analgesic definitely helps. That brings me to the end of this literature survey, and thank you very much for your patient hearing. Thank you.
Thank you, madam. That was such a nice, elaborate talk. You took us right from doses to their side effects, then to the literature and what are the latest guidelines. Oh God, I never thought actually the topic will be so varied. Each speaker has done their job so well. Thank you so much,
Thank
madam.
you. Thank you so much.
You have covered most of my talk. I'll just revise. It's actually just a combination of all the talks. I'll just share my screen. Yeah, 1 minute. And this. Is it visible?
Not yet, Shilpa.
No? Okay. No, screen is not playing. I'll try to join again.
Ma'am, you have not started the screen sharing yet.
Yeah, but actually, Akhilesh, I had 1 minute. I'll just.
I think Dr. Shilpa's screen is lost. We can discuss at our level in the meantime while she comes back on screen.
So there was.
You're there?
Yeah, there was question of Themicet and scopolamine.
Okay. Good.
Akhilesh has to add me again.
Ma'am, actually, If you are on Zoom right now, I can guide you. Are you on Zoom right now?
Yeah, 1 minute. Akhilesh, me, I'm on Zoom only, Akhilesh.
Okay,
I
so
have joined again.
No, not a problem. Actually, तुम्ही actually जी presentation आहे ते दुसऱ्या विंडो मध्ये ओपन आहे का तुमचं?
हो.
ओके, तर मग झूम वरती आल्यानंतर शेअर स्क्रीनला क्लिक करा एकदा.
1 minute, yeah.
हाँ, तिकडनं स्क्रीन सिलेक्ट करा.
हाँ, पण ते okay. Yeah.
हाँ, visible आहे.
I'm so sorry. Yeah, sorry for the delay. As everyone has nicely enumerated all the guidelines, all the pre-operative precautions, intraoperative measures, I have to just brush regarding the 4th consensus guidelines for management of post-operative nausea vomiting. Yeah, so this consensus statement presents a comprehensive and evidence-based set guidelines for PONV. Now, from where they have reviewed the literature, they have reviewed literature till September 2019. And as Shweta Madam said, who has formulated these guidelines, the American Society of Enhanced Recovery and Society for Ambulatory Anesthesia. Now, what is new in these guidelines is that it includes the 2nd generation of 5-H3 receptor antagonist. It says you have to use dopamine antagonist also. If possible, if required, neurokinin receptor antagonist and a combination therapy. As Madam said, mostly it is multimodal combination of 2 drugs. And if there is a high-risk patient, then you have to use a combination of 3 drugs. This is for enhanced recovery pathways, nowadays ERAs, which we are using. So it includes implementation of general multimodal PONV prophylaxis in surgical patients. There are 7 factors under which these guidelines are divided. The first and foremost, which you have been continuously talking is about the risk factors for PONV. So in these risk factors, the 4 risk factors which form the AFSEL score, which are again revision, female, then you have a history of PONV, post-op opioid use, and non-smoking status. Everyone has nicely elaborated the graphs, the results. Also, may I add the patient on chemotherapeutic drugs, a younger patient. Also, there are anesthesia risk factors, as everyone has said, general anesthesia itself, volatile anesthetics, nitrous oxide, time-dependent and higher concentration of neostigmine and ketamine, neostigmine more than 3 milligram. Again, a pediatric score, EBHART score, which everyone has, Shweta Madam has nicely said what can be used in pediatrics, and certain surgeries, of course, the strabismus surgery, the tonsilloadenectomy, which causes more risk. So while we are at the guidelines, first we should identify the patients at risk. Second, what they say, reduce the baseline risk. How will you reduce? By using regional anesthesia. We all try to do it. Secondly, opioid sparing techniques. In between, we had a surge of all the anesthetists using opioid-free anesthesia. I think more or less we should practice that. Preferential use of regional. Then propofol infusion is more likely to cause less nausea, vomiting than the volatile anesthetic agent. And one point which is stressed everywhere is the hydration of the patient, which we have to maintain. So this is a baseline risk. You create a base where you avoid this baseline factors. Third is administer prophylaxis with 2 interventions is adult with risk. Now here they have said that ondansetron, the 5-HT3 receptor antagonist, remains the gold standard. Then over it, you can add antidopaminergic corticosteroids or antihistaminics or any non-pharmacological prophylaxis. The 4th point, which they have said that sometimes if the surgical time is less than 30 minutes and the patient does not have any risk for PONV, the caregivers may avoid the antiemetics prophylactic. Then they have said that in an adult, mostly you should use the combination. The fifth point which they state is, to provide an antiemetic treatment to the patient who has not received prophylaxis or when the prophylaxis has failed. The most important thing, suppose you have given ondansetron to a patient. As madam said, don't use more than 16 milligram, right? Here what they say, repeating the dose within 6 hours of the same antiemetic usually does not help. The sixth point is, ensure general multimodal post-operative nausea vomiting prevention and rescue treatment. So set up your own guidelines, what you are going to use. Here I would like to say that the guidelines which Shweta madam said, paracetamol is always used as an antiemetic preoperatively as well as preemptive analgesia before the incision. Similarly, I use dexamethasone, ondansetron, and metoclopramide. The authors have reduced the threshold for administrating multimodal PONV prophylaxis. So here, this is a very important point. Remember that don't always look at the risk. With slightest risk, you have to use multimodal PONV prophylaxis. Here, Maya madam may differ and may not use dexamethasone, but in high-risk males also, as the latest guidelines say, we should use 3 antiemetic prophylaxis. And the last thing, administer multimodal prophylactic antiemetic, which helps in enhanced recovery pathway. Now, in 2016, as Shweta madam said, they had come with the statement that the number of medications used for treatment and prophylaxis should be determined by the number of modifiable and non-modifiable risk factors. So that should be maintained. Also, they had come with the guidelines that all patients should receive PONV prophylaxis during the perioperative period. And in fact, as Kala madam said, that only 2 things bother us in the post-operative period for a general anesthesia patient, the pain and nausea vomiting. So if we are able to control this, nothing like it. In fact, if you see a patient who has surgery 10 years back, first thing the patient will say, operation के बाद मुझे pain नहीं चाहिए, मुझे nausea vomiting नहीं चाहिए. And the last thing, the panel agrees that with these statements in the updated guidelines, the recommendations for PONV management in enhanced recovery pathways should be used for specific type of surgeries. Thank you, everybody. Yeah. Yes. With this, we'll take the chat box questions later on. We'll go on to the next speaker, Dr. Sunita Khedkar madam, for treatment of post-operative nausea vomiting. Dr. Sunita Khedkar madam, are you there? Yeah, welcome madam.
Thank you madam. I'm sharing the slide.
Yeah.
Is it visible, ma'am?
Yes, madam.
Good evening, all. Thank you, ISA Borivali branch, for giving me this opportunity. This topic already explained by all the speakers, so I will go through quickly. We will see the causes. Actually, these are already discussed in the previous lecture. Then need of treatment and drugs in detail, and treatment of post-op nausea vomiting. Then these are the causes already discussed in detail, which leads to post-operative nausea vomiting. Usually opiates, which are used perioperatively. These are the most stimulating and emetic agent. Then increase intracranial pressure, hypoxia, oxygen deficiency may lead to emesis, then infection, pain, and blood draining down the throat. Then the patients group, who are at risk, previous history of nausea vomiting, then motion sickness, menstruating female, then children over age of 2 years, and obesity and non-smokers. These are already discussed in the previous lectures. Then what is the need of treatment of post-op nausea vomiting? Actually, this post-op nausea vomiting may lead to increase in abdominal pressure, increase in central venous pressure. There may be chances of gastric aspiration because of vomiting. It may lead to dehydration and electrolyte imbalance. Then there is increased morbidity after ocular, tympanic ear surgery, intracranial surgeries. There may be sympathetic response of tachycardia and hypertension, and parasympathetic response also there, bradycardia and hypotension. PONV may prolong the PICU stay and unanticipated readmissions and economic impact on the relatives. So these are the neurotransmitters secreted at the vomiting center: serotonin, substance P, dopamine, then acetylcholine and histamine. These are all discussed in the pathophysiology of the PONV. Then these are the drugs which acts at different receptor sites, which can control the vomiting and nausea. So we will discuss in detail the drugs used in the PONV. The group of drugs are serotonin antagonist. It may contain the ondansetron, granisetron, palanoceptrone, and dolasetron. Then dopamine antagonist, that is phenothiazine, substituted benzodiazepines, and butorphenols. Antistaminase, corticosteroids, neurokinin 1 antagonist, and others may contain the propofol, benzodiazepines, that is mirazolam and lorazepam. So serotonin antagonist, these are the ondansetron. The half-life of it is around 4 hours. The dose is 0.15 mg per kg. And granisetron, the half-life is around 12 hours. It is long-acting. We can use as a once in a day dose. Then dolasetron and palanoceptrone. Palanoceptrone has the longest half-life, that is 40 hours. So these receptors present in the CTZ and the terminals of vagus nerves in the gastrointestinal tract, which is already discussed in the pathophysiology of the PONV. These are the drugs of first line choice of drugs for the treatment of PONV. The ondansetron, dolasetron, granisetron, and tropisetron are most effective in the prophylaxis of the PONV. When given, actually it should be given at the end of the surgery. Palanoceptrone is typically given at the start of surgery because half-life of it is around 40 hours. So they have also side effects. All except palanoceptrone prolongs the QTC interval, and there are the risk of dysarrhythmias in a patient which are having hypokalemia, hypocalcemia, or which may taken the drugs of arrhythmogenic. Then the patient may experience headache, dizziness, constipation, or serotonin syndrome if they are used along with the serotogenic drugs. So the another group of drug is dopamine antagonist. The D2 receptors, actually dopamine receptors are D1 to D5, but D2 receptors are the receptors which are responsible for the post-op nausea vomiting. They are present at the CTZ and on the gastrointestinal tract. The phenothiazine, substituted benzamides, and butorphenols are the dopamine antagonists. They are act on the D2 receptor located in CTZ, and this should be used if the 5-HT blocker drugs are failed. The phenothiazines may contain the promethazine, prochlorpromazine. The substituted benzamides may contain clopramide, and butorphenol group may contain the droperidol and haloperidol. So promethazine act not only on the D2 but also on the histamine and muscarinic receptors. The dose is 12.5 to 25 mg IV, and it should be given towards the end of surgery, and it should be repeated every 4 hours if required. For rescue treatment can be given with the 5-HT receptor antagonist. It can be given orally, IV, or IM. The duration of action is around 4 to 6 hours. The metoclopramide in the dose of 10 mg IV, it is actually a weak antiemetic. If you want the antiemetic effect, it should be given around 25 to 50 mg IV, and the duration of its action is around 6 hours. It has side effects of dystonia, dyskinesia, extrapyramidal symptoms, and the confusion. So another group is butorphenols. Droperidol, it acts on the D2 receptor. Its dose is 0.6 to 1.25 mg IV. It is labeled as a black box warning because of its action on the QTC interval and the side effect of the toss adipontis. And the side effects are anxiety, restlessness, akathisia, and dystonia, and dose-dependent QTC interval, which we have already seen. The another group is neurokinin type 1 receptor antagonist. This blocks the neurokinin type 1 receptor, which are present in central and peripheral nervous system. Aprepitant is the first drug which is discovered and approved by the FDA. It prevents vomiting but less effect as an anti-nausea. It has a half-life of 40 hours and the dose is 40 milligram orally. Main disadvantage is the high cost of this drug may not be able to use routinely. Actually. The other newer drugs are cosapitant and rolapitant. The corticosteroid also has the antiemetic action, dexamethasone, which acts central by acting central inhibition of the prostaglandin synthesis and the encephalin release. The dexamethasone effectively prevents nausea vomiting in post-operative patients, but onset is slow. So it should be given at the beginning of the surgery. The prophylactic dose is 4 to 5 mg IV. Prednisolone can be also used as a 40 milligram IV. Main side effect is the post-operative infection and increased blood sugar levels, but with single dose, I don't think so it matters. The another group is antihistaminics. The antihistaminics acts on the histamine receptors, mainly cyclazine, doxylamine, and promethazine. These all acts at muscarinic receptor also. Promethazine also acts on dopamine receptors. Diamine hydraminate, it has a weak anticholinergic action. The dose is 1 mg per kg. Cyclazine and promethazine dose is 1 mg per kg IV. It has a side effect of drowsiness, sedation, urinary retention, dryness of mouth, and blurring of vision. The another group of drug is anticholinergic. The scopolamine patches, transdermal scopolamine patches are available 1.5 mg. It should be actually applied the evening before the surgery or 2 to 4 hours before the start of anesthesia due to its onset of action is late, around 2 to 4 hours. So it has also side effects, confusion, delirium, hallucination, urinary retention, visual disturbances, and pupillary dilatation. The other antiemetics are the propofol in subhypnotic doses. It acts as an antiemetic in small doses, like 20 mg can be used as a rescue antiemetic. Propofol can be used as a preventive measure in TIVA or during induction for the maintenance. Gabapentin already discussed. It can be given 600 milligram orally 2 hours before the surgery for decreasing PONV. Injection Mirazolam also has a role in the prevention. It can be given just before the surgery. The literature says that you can give as a preventive measure as a sedation so that it can prevent the post-op nausea vomiting. Lorazepam also can be given 1 mg orally 60 minutes before general anesthesia. And the another group is alpha-2 agonist, also clonidine, dexmedetomidine, shows the significant but weak anti-nauseatic effect. The main treatment part is according to the cause of the PONV. You should treat the cause first. If patient having dehydrated hypotension, it should be corrected with adequate fluid hydration. The NBM hours should be less. The pain control should be adequate. If possible, with the NSAIDs, with the blocks post-operatively. If no prophylaxis was given, the recommended first line of drug is 5-HT antagonist. The treatment should be administered with an anti-emetic from a pharmacological class that is different from the prophylactic drug initially given. The dose of 5-HT used for the rescue should be smaller than the use for the prophylaxis, but this dose should not be repeated within 6 hours of first dose. So, the combination therapy is most effective way to control the PONV with less side effects. The 5-HT antagonist in combination with droperidol is associated with low risk of headache and other side effects. The 5-HT antagonist can also be effectively combined with the dexamethasone. The acupuncture and acupressure are the non-pharmacological techniques which can be used along with the antiemetic drugs. So the preoperative and intraoperative preventive measures to control the PONV is very important. The 5-HT receptor antagonists are the first line of drug of choice. According to the cause of PONV, drugs should be used. And combination of antiemetic therapy is effective in treating the PONV. Thank you, ma'am. Thank you, Shilpa ma'am. I have finished my talk.
Thank you, Sunita madam. Thank you so much. Yeah, it was a good revision. And we can take now the chat box questions. Madam, Sunita madam, can you stop sharing screen? Yeah.
Yes.
Yeah, there was a query. Do we have our panelists, Shweta madam or Maya madam, whoever can take these questions? Whether anyone uses Themiset? Shweta madam, are you there?
Yeah, I'm there. Well, no, I think the cost is the major factor. So we haven't used it. So standard protocol is our ondansetron and dexamethasone that is being used commonly for all our patients. And so we don't have the experience, but I'm sure in Tata Hospital and where they are giving chemotherapy agents, there it has been quite a bit of a standard to use palanoceptrone, and it's known to be very, very effective. As we say, we know that the half-life is pretty much long. So a single dose 0.75 milligram IV is going to be very acting for 40 hours. So that's quite helpful.
Okay. Do we have Vijaya Patil madam on board? Yeah, anyone has to say anything? What about scopolamine patch? Shweta madam?
No, I haven't used it. I don't know whether, is anybody using it?
Yeah, Dr. Rao sir has asked about it.
Yeah, no, what I'm saying, I'm just asking all the participants as well as the people who are there on board, whether I haven't used it, neither do I know whether it is available in our nearby market. So I'm not aware. I'm sure it must be. So I just want to know, because I really have no knowledge of this, of its use, but what literature have said, I've just talked about that it's very good as a transdermal application.
Scopolamine is a drug which was used during Second World War. It was popular those days. I wonder if anybody else uses that drug now.
I'm sure not in our city, but I'm sure somewhere they must be using. If the literature is showing so much of an evidence, I'm sure people are out there might be using.
Hi, Shweta.
Hi, Parna.
Hi. Hello, Yogin Bhatt sir. Shilpa. Yeah. When I was in the US, we were doing a study on PONV. So we had studied scopolamine patches also extensively. And it gives very good result, and it's very convenient to use them, like fentanyl patch or any other patch. And it gives very good results. So patients who are at high risk, like high APFEL score or something, you can definitely use them. So it's not available in India, but I don't know if it's available now. I don't think so, but it's a very good drug.
Yeah, that's what I said. If there's so much of literature about it, I'm sure there must be some use of it.
Yes, yes.
Yeah, one more question is there, that ondansetron is used at the end of surgery. Everyone says you have to use it at the end of surgery. Intraoperatively, nausea, vomiting in regional patients. Anyone wants to take it? Dr. Minal Gadgil, Dr. Anita Roy, Dr. Vijaya Patil, Dr. Maya Bhalerao Madam, Dr. Pradnya Bhalerao Madam. Intraoperatively, do you want to give a regional patient ondansetron? I usually give it intraoperatively after regional anesthesia. I give ondansetron, metoclopramide, ranitidine, as well as dexamethasone. Yes, anyone want to comment? Dr. Ganesh Tendulkar, sir, you were saying something about dexamethasone. Dr. Dipali Kotian.
No, madam, just there was some divergent views about dexamethasone use regarding being used as antiemetic. I just wanted to stress that dexamethasone also lowers the pain scores. So even lesser pain scores also shall contribute to less nausea, vomiting in post-operative period.
Yes, I agree. Yeah, with this, but sir, we'll conclude our session. Yeah, and we welcome our MISA office bearers.
Just
Shweta madam, you have to say something.
Just for dexamethasone, the recommendation is to use at the induction. Steroids to be given at the beginning of the...
Yes, agreed.
So there's a lot of evidence in the literature which says when to give it. That's what I said, that not only the dose and the route, but when to give it also must be looked into and used appropriately with the knowledge. It definitely helps patients.
Yeah, so by the time the arrangements are there for cake cutting, and we have our MISA office bearers, our president, Madam Dr. Manisha Katekar, Madam. I am so sorry. Yeah, I'm so sorry. Yeah, Dr. Siddharth Verma, sir, has joined. We'll have a short talk with Dr. Siddharth Verma, sir. Yeah, welcome, Dr. Siddharth Verma.
Don't call me sir, ma'am. Thank you so much for the kind...
Yeah. Actually, I did not see you joined. Yeah, sorry so much.
It's okay, ma'am. No problem. Actually, pain is like this only. Often everywhere, but often nowhere. So
I'm really
my talk
sorry.
is... No,
other than post-operative nausea, vomiting, as Dr. Kala said, it's the pain which worries us. Yeah.
Yes. So I think I'll just take a very short talk, and I hope, first of all, thank you for letting me present a pain topic in a PON with this thing. It is incidentally also the foundation day of ISA Navi Mumbai. So with the ISA Borivali, I'm very happy to share this close association, and thank you. I much appreciate. So this small talk is about pain medicine. It's not about a block. It is just a matter of attitude, I believe, and changing scenarios. And I will just put some light on it. What is a block or a nerve block? I think it is a very easy question, but probably the definition is much difficult, as we'll see. So if anybody can just quickly type in the chat box what is a nerve block, that will be great. I will have some statements now. Let's get involved, and I want you all to just type true or false in the chat box. So does a block means interrupting nerve supply? Is it true or false? Please type in the chat box, guys, and let me see how many of us are actually active and listening. Okay, so Dr. Neelam has typed false. Dr. Shilpa says yes. Okay, good. Let me have some more answers. Okay, so we have much of yes. Okay, great. So most of us are agreeing, Dr. Neeraj, Dr. Vasantha, great. So I think this is correct statement. It's true. Actually, block means interrupting nerve supply. So this is correct. Let's go to the second statement. There is no difference between a block and a neurolysis. So let us type the answers true or false. Just type true or false. There is no difference between a block and neurolysis. Whether it's true or false. Let me have the answers. Okay, false, 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 false. Great. Thank you for answering this as well. So that's absolutely correct. So this is a neurolysis is different and block is probably different. And let us see now how many of you can answer this one. MIPSI is just a fancy name for the block. True or false? So maybe I think this is the second last question. We just have only one answer after this. Let me see what you all think. MIPSI is just a fancy name for the block. MIPSI means minimally invasive pain and spine interventions, which usually the pain physicians will do. So true or false? Okay, somebody's saying true. Somebody. Okay, great. So let's, somebody says false. Dr. Ghosh says false. Okay, so it's not just a fancy name for the block. As we will see, Dr. Ghosh, you are absolutely correct. So transforaminal, transforaminal epidural MIPSI is a form of a nerve block. So how many say true? How many say false? Can we have the answers? Okay, so, Dr. Palvi says yes. Dr. Neelam says true. Dr. Neeraj says true. Dr. Vasantha says true. Okay, but the correct answer is that this is false. It is not a form of a nerve block, as we will see. I will, in my short talk of say 10 minutes, I'll just clarify all these things. We have one more true false, and then we move on to the talk. Joint injection with steroids. So many of the pain physicians, we do joint injection with steroids. Is it a form of intra-articular block? So just type true or false. Joint injection with steroids is a form of intra-articular block. Let us see how many of you get this one correct. Okay, so most of you have got this correct. Dr. Neeraj, Dr. Palvi, all of you have got this correct by mentioning that it's false. Dr. Vasant has also got it correct. So I think most of the things are absolutely clear, but let me go on to what is a block. Actually, if you see, the definition is pretty straightforward and why it is not about the block. So a nerve block is a one-time injection of a numbing medication around the nerve, and a continuous nerve block means a few hours or in some cases a few days. So this is very important because this is what differentiates a block from what probably a pain physician will do. And why pain physicians don't block? The answer is it only for diagnosis? Because the patients who come to us in pain, they come for a long-term relief. So many times, more often than not, it is not just for the diagnosis, whereas it is usually for the treatment purpose, and people are looking for a long-term relief. So they are not concerned whether you give them temporary 1 hour, 2 hours, 5 hours, 5 days of relief. They want a long-term relief. So that's why usually the pain physicians won't block. Now, there's a misnomer, which is many of you already got this correct, but still in our normal terminology, we use neurolytics, we use it interchangeably with a block. So probably we want to say that it is a permanent kind of a block. So we, as pain physicians or even some of the anesthesiologists, we are doing, because our mother branch is anesthesia. So we do a lot of these procedures, these neurolysis. So the pictures which I have shown is for sympathetic neurolysis. And if you see, these all are very different from the blocks which we do. If you put a local anesthetic, although the needle placement is the same, everything is the same. The only difference is what you are going to do there. And if you if you think on it, the radiofrequency ablation is also a form of neurolysis. So the correct word to use here is neurolysis. Now, how does it make a difference? It definitely makes a difference in the practice of a pain physician, as well as it makes a difference to your patient as well. So to overcome all these issues, Indian Society for Study of Pain, which is the Indian chapter of International Association for Study of Pain, they came up with this terminology of MIPSI. So MIPSI is nothing but a minimally invasive pain and spine intervention. So they grouped all these conditions, they classified it, and they coded all these conditions and these procedures, and they differentiated it from the word block. And they gave a reasoning, and they gave, it's all published, and this was published in the Indian Journal of Pain, and it was endorsed by the other society also, that pain. So how does it make a difference? It makes a difference because many of us think that ek block de do, acute pain and chronic pain is the same, labor analgesia is done by pain physicians. So all these things are, there is a fine line which is there, which exists, and we forget to remember this line, that no chronic pain per se, acute pain is already taken care of very well, and probably much better than pain physician. Anesthesiologist is supposed to take care of it, but now the line is being drawn, wherein the chronic pain, cancer pain, joints, minimally invasive management, we are now going into endoscopy and whatnot. So this line is gradually making its presence felt now, and this makes a lot of a difference. Now let us see how a pain physician usually treats the patient. So of course he takes a history, rules out the red and yellow flags and everything, then goes to conservative management or rehab, but then he goes to what is known as these MIPSIs. So this clubs a lot of different things which can be diagnostics and therapeutic. So the radiofrequency ablation, the adhesiolysis procedures which are done with saline or steroids, and neuromodulation, which is also a complete branch in itself, whether it is a spinal cord stimulation or peripheral one. It's also fast picking up. And of course, the regeneration therapy, which was until very recently known as experimental, but now is gaining FDA approval very fast for a lot of conditions. So this is quite different than your usual block approach. So this is not the block, this is not the block, this is not the block, this is not the block. The only thing which is common here is the technique and the expertise and the ease with which an anesthesiologist, by virtue of their training, can perform these procedures. So we are the best suited ones. Not to forget that even the father of pain medicine, John Bonica, was himself an anesthesiologist. So by virtue of our great mother branch, we are very well positioned to take this role of pain physicians, but there's a difference in the techniques which will be practiced. So here is this personalized new branch of pain medicine. We are now having a DM also in pain medicine, and which is consisting of minimally invasive procedures. The practitioners of this branch like to call themselves as spine and pain physicians, who do all sort of procedures from endoscopies to spinal cord stimulation to ultrasound guided procedures, which can be injections of regenerative fluid and lot many things as well. So journey of a typical pain physician today is very different than what it was like the seniors who have taught us. Their journey was quite different, but a typical pain physician today will finish his DA, MD or DNB, then join a pain fellowship or DM in pain medicine if he is lucky and can compete, and then start his pain practice and just join CME for staying updated. I hope you remember this guy, if those of you who follow Instagram. So it's that simple, and it's become quite easy. The efforts of our seniors have given us these opportunities, and I think most of the youngsters are taking up this path. Many of the problem, however, is that the awareness is still lacking, and while we are doing our PGs, we are not aware of how to get into this challenging field. And as a result, probably we have started some awareness activities, and this particular lecture is also part of them. So a day in a life of pain physician is very different than a day in the life of an anesthesiologist. So probably we will have our OPD day, just like the pre-anesthetic checkup. The full day will be spent in the OPD seeing patients who are suffering from all sort of chronic pains. And then we have the OT day, but herein we are not going to give the anesthesia or give blocks, but we are going to do the procedures which are permanently going to give relief from the pain. And of course, we are going to do lot more of webinars, public awareness sessions, commercial or social or advertisements, branding. So lots more. These are much heightened for a pain physician, and most of our days can be, on some days can be spent, for example, Sundays can be spent doing this. And of course, we also get to a lot more credit than usually an anesthesiologist usually gets, because that credit is taken in those cases by a surgeon usually, but we get a lot more credit for the success of the procedure as well. So this was it. Thank you all for listening. And with these words, I also take the opportunity to invite you for our upcoming Cadaveric workshop, which is the next weekend. And those of you who are interested, it's all over. You can just Google or go to Facebook and search for Mumbai Pain School, and you get a lot more information. I thank the organizers once again for arranging such a wonderful celebration and allowing me time to speak. Thank you very much, ma'am.
And Dr. Siddharth, yeah, once again, sorry and thank you. That was a good insight in pain. No, we don't forget pain, but you look at pain at a different aspect. And with that fame, you have a lot of responsibility when we refer patients to you. Thank you so much.
Thank you so much.
Yeah, yeah. Thank you, sir. Yeah, now we welcome our MISA office bearers. President, Madam.
Yes,
President, Madam, Dr. Manisha Katikar, Madam.
Good evening.
Madam, good evening. Nice to see you. You are at work at this time?
Just finished. There was an emergency case. I spoke to you in the morning. No? Just finished that.
Okay, okay, madam. Welcome our national GC member, Dr. Ashok Deshpande, sir. Welcome, sir. Yeah. Welcome our Vice President, Dr. Anita Nehete, madam. Dr. Anita, madam. Maybe madam is joining again. Welcome our President-elect, sir, Dr. H.K. Sale, sir. Sale, sir, are you there? Welcome to our Honorary Secretary, sir, Dr. Avinash Bhosle, sir. Hello, sir. Sir, you are on mute.
Unmute.
Unmute kara, sir.
Hello. Hello. Good evening, sir. Everybody.
Good evening, sir.
Good evening.
Welcome to our Treasurer, Dr. Samir Sohni, sir. Dr.
Hello.
Samir. Hello, sir.
Hello.
Yeah, nice to see you.
Sorry, I am driving right now, so can't put on my video, but I am trying to listen to the academics also. Nice to hear about pain and all that from Dr. Siddharth. I couldn't log in before that. But thank you. Thanks.
You heard the most important part.
Yeah.
And
thank you, ma'am. Thank you.
Then we have our MISA news editor, Dr. Hemant Shinde, sir. Yeah, and I would like to include with our MISA office bearers, our cultural committee member head, Dr. Maya Bhalirao, madam. And of course, along with the MISA office bearers, our patron member, our motherly figure, Dr. Indrani Hemant Kumar, madam. Welcome you all, and thank you for joining us for a virtual cake cutting. Wish we could give you a piece of it actually. Yeah, over to you, Bhatt sir.
Thank you, Dr. Shilpa, and I thank the whole team of Maharashtra ISA chapter, starting from the president-elect, secretary, and the treasurer. I always keep Samir Sohni as my dearest friend because he has become treasurer now. And I welcome all of you. I welcome all of you. We'll now have a small ceremony of cake cutting We all are sitting in Borivali ISA office only. And I request Dr. Shilpa, the youngest member, to cut the cake. Or please cut.
Sir, our treasurer is also important.
Treasurer only pays for it.
Yes.
Congratulations and best wishes.
Congratulations.
Thank you.
Congratulations. BSA.
Happy birthday.
Congratulations.
Thank you.
Congratulations and celebration.
I compliment Dr. Shilpa because all branches are getting birthday, but she gets the ideas of celebrating this. Getting an idea and implementing is a different thing.
I think we should create one post where that post the person will courier the cake and all these things to everyone, every branches.
So one webinar I had done that actually. I saw to it that because the webinar goes on till 8:30 or so, and by the time children at home start making music, so I saw to it that everybody, all 160 members of BSA, got one food package. We had sent it to all members through web service.
So now we should request MSc ISA office bearer to create one post in this online era.
Cake officer. Cake officer of cake secretary.
They can always send me the cake. I am very nearby. Please do.
We request Dr. Manisha to give a message of thanks, and then we close
welcome for the state CME all BSA members.
We close the session then.
Yeah. I'm really waiting for the piece of cake, and if I get tonight, then definitely that post of cake operator will be created in the MSc.
You see, I have ordered a very small, tiny piece of cake because we are only 3 of us. Who is going to eat a bigger one?
Yes, sir. It is really a wonderful evening to be with you all. Dr. Kamdar sir, Dr. Yogen Bhatt sir, then Preeti, Shilpa madam, Neelam madam. Such a nice evening to see you all together on the platform of ISA Borivali. I must say, I must congratulate you for this event. You all started with a few, but now there are so many of them. And not only in number, but in great creativity as well as great efforts and talent. Congratulations, all of you. I'm really happy to see the progress of ISA Borivali, especially when in this ISACON Ahmedabad, you got so many awards. And I must say that you deserve all the praise. You deserve many congratulations for this remarkable milestone. I'm sure that this journey of success will definitely continue. And in the coming years, we'll get to see many and many awards. And looking forward for a great CME from all of you in the year 2022. Thank you so much. Thank you so much.
Mostly, sir, you would like to say something?
Yeah, good evening, everybody. As the Honorary Secretary of Maharashtra State Chapter ISA, I wish all the members of ISA branch Borivali all the best.
Thank
On
you.
this joyous occasion of 7th Foundation Day, I congratulate you all for your extraordinary achievement in so short period. As I always said, your branch is rapidly progressive dynamic branch. So on this previous occasion, I take opportunity to felicitate virtually a diamond of branch, Dr. Kamdar sir, a gem, Dr. Yogen Bhatt sir, and 4 golden stars, Dr. Shilpa, Dr. Preeti, Dr. Neelam, and Dr. Madhubala madam, who had taken the branch at great height and to the state and national level. I request all the members of branch to take active participation in a coming CME of Maharashtra State Chapter. I am sure it will be a grand success and you people will definitely do it in a different style. During this process of CME making, you will make lot of friends and unity among you, and your branch will become more stronger. So everybody should take part म्हणजे आपल्या घरचंच लग्न आहे असं समजा, म्हणजे प्रत्येक जण भाग घेईल.
आम्ही पाच सवाशिणी रेडी आहोत ओवाळायला तुम्हाला.
And don't wait for call for help for this occasion. Okay.
We are totally banking on help from all
everyone.
सगळ्या
आजूबाजूच्या लोकांना म्हटलं यायचं.
लग्न आहे. So everyone is, nobody is invited. Everyone हक्काने.
Yes, हक्काने.
हो नक्की. पुन्हा एकदा सर्वांचे अभिनंदन आणि खूप खूप शुभेच्छा. Wish you this function a memorable to all and a grand success. Thanks for inviting me in this occasion. Jai ISA, Jai Maharashtra State ISA. Thank you.
Thank you. Thank you. I would just like to say 2 words of thanks. One to Dr. Indrani, who has always been a guide and guru to all the branches that are there in Mumbai. And personally to Dr. Sunil Katkade, who was my guru. I learned anesthesia as well as this management under him. So I really
salute to both of them.
Yes.
Jana sir and join झाले तू.
Joyce and Jana, welcome. You have always been exactly always behind us and pushing us to reach newer heights. Thank you very much, sir. Thank you. And Deshpande sir is always there. Always. For so many years, I see him and we are always together in all conferences. We never miss that appointment.
Almost all conferences.
We travel a lot. We enjoyed meeting, and I think our basics were same. Yes. We started association to help the nursing home anesthesiologists. And gradually it has merged into ISA, and now all of us have gone to a national level, and you all are doing a great job. I'm really appreciate and salute Dr. Yogen Bhatt for organizing a great team, and he comes with all novel ideas and implements them. Thank you very much, and all the best, and we all are there with you for national series. Go ahead. All the best. Long live ISA, long live ISA Borivali, long live ISA Maharashtra.
Thank you. Now just 2 words of thanks from our
I just want to say one word.
Yes. Yes, madam.
Yes, yeah, actually I'm traveling, but
we saw that.
Looking into all this. So from the days it used to be called Northwest, right?
Practicing anesthesiologist.
Practicing anesthesiologist.
Dr. Kamdar's baby, yes.
Yeah, from that time till now, sir, Dr. Kamdar sir, yourself.
You have been associated with us, yes.
Yeah, we've been associated, and that sense of warmth which you gave all of us is perceived even today. And to add to this, now you have an entire gamut of people and very effervescent people like Preeti, Shilpa and Neelam and all of them. And, the whole thing is looking, the whole association is looking so good that I'm really, really happy to see its growth, till to it. And in future, I only wish the very best to all of you. And finally, congratulations and happy birthday all over again.
Thank you.
Thank you so much.
I would like to share one happy news with you all, that today is our 10th glorious year we are completing, and tomorrow we are having a grand function. You all can join.
Congratulations.
Yes, thank you so much. And this cake cutting, I thought it is for my SAPC branch also. So I enjoyed that and wish you all the very best. Congratulations once again. I know you're doing wonderful job, and the CME would be a great rocking event. Thank you so much. Thank you for inviting SAPC President, Secretary and GC member. Thank you so much, and best wishes.
Thank you everybody. As a treasurer of the coming MISACon, it is indeed a very daunting, what should I say, a very daunting project for me. And when Manisha madam said, all of you are doing so well and so good, and even Indrani madam had such lovely things, all of you had such beautiful things to say. But Marathit मी एवढंच म्हणणार की पुढच्या मोठ्या होडीला बघूनच पाठच्या छोट्या होडीला वाट मिळते. So everything we are getting or we are doing today is absolutely, with guidance of our seniors, be it from our branch itself, like Dr. Kamdar, Dr. Bhatt, and so many other seniors that are there. And also at the state as well as the national level. So we are totally banking on you, and हक्काने आम्ही जरूर तुमच्याकडनं मदतीची अपेक्षा करतोय. And I'm very sure that all of you are going to be with us. And thank each one of you from the bottom of all our hearts from BSA for joining us and making this such a beautiful celebration. Thank you once
again. It is also birthday of ISA Navi Mumbai.
Oh, great.
Well, just so, yeah.
So many of us are born on this day. So it is a very good day. Muhurta changla hota.
Yeah. So maybe next year we will celebrate together.
Thank you. Compliments, Dr.
Yogen.
Yes, sir.
Yogen, where is Dr. Kamdar, sir?
Yes, Kamdar sir, Chicago मध्ये बसून बसले असेल. उठले असेल आता.
दिसत नाहीत पण. He is my teacher. उसको मुझे नमस्ते करना चाहिए सर को. He was my teacher.
But probably he must be
Bhagwati Hospital. Bhagwati
he
Hospital.
He must be traveling somewhere. Otherwise, he normally attends his web.
Yeah. I know.
Okay. And I am so glad that you all have spent time to attend this meet. Dr. Deshpande, Indrani madam, I am seeing her for almost an hour in the car. She must be fed up with it, but still willing to be with us in this meet. Thank you very much. Thanks a lot. This really makes us all proud. Thanks. Sir.
This is the branch which we love. This is the branch which we love too much.
Yeah. And we should thank you in fact, that you made us that part of your celebration.
Thank you. Thank you. I think we can wind up session, Secretary Madam.
Thanks a lot.
Yes, thank you everybody for joining. Thank you for your precious time.
केक पाठवणार की 8 दिवसांनी येणार केक.
ऑनलाइन
सगळ्यांना फ्रेश केक्स at मिसाकॉन.
वाउचर आता मध्ये जीसी मीट येईल ना.
वाउचर जीसी मीट मध्ये वाउचर पाठवते केकचा मी सगळ्यांना.
That's a good idea. Very good idea.
Not a bad idea. It can be planned.
No. If Preeti approves, then only I can send. Otherwise, I can't send.
Approved from national.
Thank you, sir. Thank you.
Bye all and best wishes. Bye.
Thank you.
Thank you.
Thank you.
Thank you for inviting. Thank you. Bye.
See you again.
Bye. Best wishes. Yes.
Thank you all. Congratulations.
Yeah, thank you.